Hi, my name is Tim Jen, and I'm the Regional Anesthesia Fellow at St. Paul's Hospital. Today we're going to talk about IV and perineural dexamethasone and dexmedetomidine in peripheral nerve blocks. Our game plan is this. We will talk about what happens without adjuvants, perineural versus IV dexamethasone, optimal perineural dexamethasone dose, optimal IV dexamethasone dose, perineural and IV dexamethasone, perineural versus IV dexmedetomidine, optimal dexmedetomidine dose, dexamethasone or dexmedetomidine, and finally, dexamethasone and dexmedetomidine. See, the real problem is rebound pain. In 2015, Abdallah et al. Did a systematic review of single-shot interscaling versus general anesthesia and systemic analgesia, and review its effect on pain scores for patients undergoing shoulder surgery. Included were randomized control trials, and important exclusion criteria included any study that had continuous catheter or any adjuncts other than epinephrine. 23 randomized control trials were included with 1,090 patients. It is found that the duration of pain relief at rest was 8 hours, with worst pain score at 16 to 24 hours. Similarly, there was no difference in dynamic pain beyond the initial 6 hours. The conclusion is that there is minimal beneficial effect of single-shot interscaling block for shoulder surgeries of only 6 to 8 hours at the cost of rebound pain at 16 to 24 hours without the use of adjuvants. Some people then argue that there is economic benefit to performing regional anesthesia single shot regardless, but we're still saving money by making the discharge faster. To look into this, Hamilton et al. Published in Anesthesiology 2019 large retrospective population data in Ontario with data from April 2009 to December 2016 for Ontario adults undergoing ambulatory shoulder surgery. This included 59,644 patients across 118 hospitals. There's no difference in the composite score of adverse postoperative outcomes with or without peripheral nerve block. The composite score included unplanned admission, readmission within 7 days, ED visit within 7 days, or death. And this is after multi-level, multivariable adjustment. However, if you look within each component, you see that there is decreased unplanned admission with the use of peripheral nerve block, which is concordant with our observation that we're able to discharge them no problem. However, more of the subsequent ED visits for those who do require it are secondary to acute pain with the use of peripheral nerve block, and this is also concordant with our observation of rebound pain. As a secondary outcome, Hamilton et al. Discovered that there is actually more cost of $325 with the use of peripheral nerve block than without. And this goes against the argument that we are saving the healthcare system money by performing single-shot peripheral nerve blocks. The question is then, at the cost of increased healthcare spending and increased rebound pain, how can we provide optimal acute postoperative pain relief with single-shot peripheral nerve blocks? Because ultimately, patient experience and satisfaction are not captured by large population cohort data. First, we'll look into the guideline. The PROSPECT guideline, which stands for Procedure-Specific Recommendations for Postoperative Pain Management for Rotator Cuff Surgeries, specifically recommend that preoperatively we should use multimodal analgesia, including acetaminophen, COX-2 inhibitor, and a regional anesthesia technique, whether it is interscaling block or suprascapular nerve block with or without axillary nerve block. Intraoperatively, it recommends IV dexamethasone and arthroscopic surgical technique, and postoperatively it recommends opioid as a rescue analgesic. There is limited evidence for perineural adjuncts, including opioid, glucocorticoid, or alpha-2 agonist. To look into this further, it says that although there is limited procedure-specific evidence, IV dexamethasone is recommended for its ability to increase the analgesic duration of interscaling block and decrease supplemental analgesia use, as well as for its antiemetic effects. On the other hand, it says that limited procedure-specific evidence was also identified for perineural glucocorticoids. Nevertheless, we recommend using IV dexamethasone over perineural administration. Unfortunately, the text does not go further into the reason why it recommends IV over perineural dexamethasone. Therefore, we must look further into literature to reach our conclusion. And the answer is this. For perineural versus IV dexamethasone as an adjunct, perineural appears to be more efficacious for upper limb blocks. However, safety data is lacking. There was a Cochrane review published in 2017 that looked at dexamethasone as an adjuvant to peripheral nerve blocks. Overall, the Cochrane review searched from the databases from inception to 2017, all the randomized control trials, and overall this included 35 randomized control trials covering 2,702 patients. 33 of these trials were upper limb and 2 were lower limb. Based on a subgroup analysis comparing the duration of sensory block for perineural versus intravenous dexamethasone, what they found is that the duration of sensory block was longer for perineural dexamethasone by 3.14 hours. However, there was considerable heterogeneity in these studies as they defined the duration of sensory block variably. There is also a decrease in postoperative pain at 12 and 24 hours, but not at 48 hours for perineural dexamethasone administration compared to IV dexamethasone. There's no difference in cumulative 24-hour opioid consumption. Similar results were reflected in 2 subsequent systematic reviews and meta-analyses that were also published in 2017, and similar results were seen for 2 subsequent randomized controlled trials published in 2018. One of the big concerns for the use of perineural dexamethasone is its safety profile. Based on a subgroup analysis of the Cochrane review, 3 studies looked at the incidence of numbness and tingling 14 days after surgery. Of these 3 studies, only Rahengel 2014 was lower limb. For these 3 studies, there is no difference between perineural versus IV dexamethasone in the incidence of numbness and tingling 14 days after, both of which were 4 out of 116 patients. The conclusion is that there is no known difference yet from randomized control studies. However, because of the low number of patients, this is likely not powered enough to detect such differences yet. As a result, we have to rely on prospective observational study to inform ourselves. In 2018, Kahn et al. Published a prospective observational data looking at patients undergoing foot or ankle surgery receiving ankle block or popliteal sciatic block from October 2012 to October 2014. Of note, the blocks were done with or without dexamethasone based on surgeon or anesthesiologist preference. This was non-randomized. The study included 2,560 patients undergoing 2,759 foot or ankle surgeries. There were 195 complications that were neurologic or at the block site, 83 of which were felt not to be related to the block. In popliteal sciatic block, perineural dexamethasone use was associated with increased complications with an odds ratio of 2.06. In ankle block, no difference was found. The authors cautioned regarding the interpretation of this data in their conclusion due to the non-randomized nature of this study, which can potentially lead to confounders. Therefore, we must look into the primary literature for evidence. And the bottom line is this. For dexamethasone, perineural administration for upper limb blocks appears to be more efficacious. However, safety data is lacking. So what is the optimal perineural dexamethasone dose? The answer is 4 milligrams. Kirkham et al. Published in 2018 Anesthesia and Analgesia, a systematic review looking at the optimal perineural dose of dexamethasone. They looked at different databases and searched from inception until January 2017, randomized control trials of patients undergoing brachial plexus blockade for upper limb operation. 33 randomized control trials were included, and the result is this. Low dose, which they define as 1 to 4 milligram perineural dexamethasone, resulted in 505 minutes of duration of analgesia, whereas moderate dose, which they define as 5 to 10 milligram perineural dexamethasone, resulted in 509 minutes of duration of analgesia. A test for subgroup difference was performed, and there was no significant difference, with a p-value of 0.97. Unfortunately, the quality of evidence was very low, with a lack of clear allocation concealment, high coefficient of heterogeneity, absence of consistent definition of the primary outcome, and significant publication bias. Of note, 8 of the trials looked at neurological complications, with very low quality of evidence, and there was no significant difference between the group that received perineural dexamethasone versus the group that did not. If you look at the forest plot, you will see that there's no subgroup differences in the duration of analgesia between low and moderate dose perineural dexamethasone. The test for subgroup difference p-value was 0.97. Subsequently, Bravo et al. Published in 2019 a multi-center randomized control trial of 360 patients undergoing upper limb surgery under infraclavicular block. These 360 patients were divided into 3 groups receiving 2, 5, or 8 milligrams of perineural dexamethasone. What they found was that there was actually no difference between 5 or 8 milligrams of dexamethasone in terms of duration of postoperative analgesia, and the difference between 5 and 2 milligrams of perineural dexamethasone was 2.7 hours, which fell within the pre-established equivalence margin of 3 hours. Therefore, the authors concluded that 2, 5, and 8 milligrams of perineural dexamethasone provide clinically equivalent sensory motor and analgesic durations for ultrasound-guided infraclavicular block. Further trials are required to compare low and ultra-low doses of perineural dexamethasone for brachial plexus blocks. Luckily, Albrecht et al. Did exactly that when they published in 2019. They published a single-center triple-blinded randomized control trial for adults undergoing elective shoulder surgery with interscaling blocks. These patients had 0, 1, 2, 3, or 4 milligrams of perineural dexamethasone, and they recruited 80 patients separated out into these 5 groups. As you can see from the graph, there is a dose-response relationship between the duration of analgesia and the dose of the perineural dexamethasone. Therefore, based on these studies, we conclude that the optimal perineural dexamethasone dose is 4 milligrams, with a ceiling effect with no additional duration of analgesia above that dose. On the other hand, what is the optimal IV dose of dexamethasone as an adjunct to single-shot peripheral nerve blocks? The answer is 4 to 10 milligrams, with conflicting data. Based on a subgroup analysis within the Cochrane review, when comparing high versus low dose, as defined by 8 to 10 milligrams versus 4 to 5 milligrams of IV dexamethasone, the duration of sensory block was significantly longer in the high-dose subgroup with a p-value of 0.00. There were a total of 3 dose-finding studies for IV dexamethasone. These include Desmet 2015, Chalifou 2017, and Holland 2018. The first dose-finding study was Dexmed 2015. It was a single-center randomized control trial looking at adults undergoing scheduled elective shoulder rotator cuff repair or subacromial decompression. These patients underwent interscaling block with 0, 1.25, 2.5, or 10 mg of IV dexamethasone, and the primary outcome was time from block to first analgesic request. Overall, they recruited 240 patients separated out into 4 groups. For the outcome, there were contradictory results based on the ways to analyze the data. First of all, the authors here reported that there was no statistically significant difference between dexamethasone 2.5 versus 10 mg. Shalifu 2017, which is the second dose-finding study, based on 69 patients undergoing elective arthroscopic shoulder surgery under interscaling block, also found that there was no difference between 4 and 10 mg of IV dexamethasone. However, back to Dexmed 2015, they also analyzed the Kaplan-Meier curve analysis, and there they said that higher doses of IV dexamethasone prolong analgesia more than lower doses with a p-value of less than 0.001. The third dose-finding study for IV dexamethasone is Holland 2018. It is a single-centered randomized control trial looking at adults undergoing ambulatory arthroscopic shoulder surgery. Overall, they recruited 140 patients in the IV arms, separated into 4 or 8 mg of IV dexamethasone. What they found is that the block duration did not differ between 4 or 8 mg with a p-value of 0.10. As you can see in the Kaplan-Meier survival curve, there is no difference between IV 4 or 8 mg of dexamethasone for the percentage without shoulder pain for hours since blocks were performed. Therefore, based on the 3 dose-finding studies for IV dexamethasone, there may be marginal benefit when comparing 10 mg to 4 mg of IV dexamethasone as a perineural adjunct in the prolongation of duration of analgesia. The optimal IV dexamethasone dose is therefore 4 to 10 mg with conflicting data. So what if you use IV and perineural dexamethasone? The answer is that there is one randomized controlled trial that shows potential efficacy. Maher et al. Published in 2017 a single-center, double-blinded randomized controlled trial based on patients undergoing unilateral VATS procedure. These patients all underwent intercostal nerve blocks as well as received 8 mg of systemic dexamethasone. They were randomized to receive either 0 or 4 mg of perineural dexamethasone, and the primary outcome was NRS at 24 hours. What they discovered was that there was lower NRS score with perineural dexamethasone administration. Therefore, this points towards a potential peripheral mechanism of action for the dexamethasone in addition to its systemic effect in prolonging the duration of action. Next, we are moving on to dexmedetomidine. Is administration via the perineural or IV route more efficacious? The answer is both work, but we're not sure which one works better or if they were the same. There was a systematic review and meta-analysis published in 2017 in BJA that looked at randomized controlled trials from January 1985 to February 2016 of perineural dexmedetomidine. Inclusion criteria was perineural dexmedetomidine in patients undergoing upper limb surgery with brachial plexus blocks. They found 34 randomized controlled trials of 2007 patients, and sensory blockade duration was increased at least 57%, and motor blockade duration was increased at least 58%. This came at a price of increased bradycardia, hypotension, and excessive sedation. Most trials had unclear or high risk of bias, with high heterogeneity in outcome results. Subsequently, Abdallah et al. Published in 2016 a single-center triple-blinded randomized control trial based on adults undergoing elective arthroscopic shoulder surgery. These patients received interscalene block and general anesthesia and were separated out into 3 groups. Control, IV dexmedetomidine 0.5 microgram per kilogram, or perineural dexmedetomidine 0.5 microgram per kilogram. The primary outcomes were duration of analgesia and 24-hour opioid consumption. They recruited 99 patients, and they found that IV dexmedetomidine is non-inferior to perineural dexmedetomidine. Looking at a table, you can see that there is no statistically significant difference between IV and perineural dexmedetomidine in terms of duration of analgesia and 24-hour opioid consumption. Looking at the Kaplan-Meier survival curve, you can see that there's no difference between perineural and IV dexmedetomidine administration. The duration of analgesia difference was within the pre-specified non-inferiority margin, suggesting that IV dexmedetomidine is non-inferior to perineural dexmedetomidine for duration of analgesia. As a result, much of the debate is whether there is a perineural mechanism of action of dexmedetomidine at all, or is perineural dexmedetomidine simply exerting its effect by being absorbed systemically. As a result, Anderson et al. Published in Anesthesiology 2017 a triple-blinded randomized controlled trial in 21 healthy volunteers. What they did is a saphenous nerve block of 20 mL of ropivacaine 0.5% plus 100 microgram perineural dexmedetomidine in one thigh, and the same block plus saline in the other thigh. The primary outcome was a duration of block assessed by temperature sensation in each leg. The results were, in a leg with dexmedetomidine, there were 22 hours of duration of block, whereas a leg with saline, there was 20 hours of duration of block with a mean difference of 2 hours with a p-value of 0.001. This actually suggests that dexmedetomidine prolongs the duration of saphenous nerve block by a peripheral mechanism when controlling for systemic effects. The consistent finding is that both perineural and IV dexmedetomidine work to prolongate sensory blockade. However, the jury is still out for whether perineural or IV works better, or if they were equivalent. Further studies will be required. What is the optimal perineural dexmedetomidine dose? The answer is 2 microgram per kilogram prolongs analgesia the best, but it is at the cost of increased side effects. Based on the systematic review and meta-analysis that we reviewed earlier, the subgroup analysis suggests that 50 to 60 microgram of perineural dexmedetomidine is the perfect dose. This balances the duration of sensory blockade while minimizing the hemodynamic side effects. At this dose, there is at least 52% increase in duration of sensory blockade, while there is a non-significant increase of bradycardia or hypotension. There are a total of 3 dose-finding studies for perineural dexmedetomidine. These include Zheng 2018, Abdulatif 2016, and Pakia Sabapathy in 2017. Zheng 2018 was a double-blinded randomized controlled trial of 100 patients undergoing elective arthroscopic shoulder surgery. They received interscalene block 20 mL of ropivacaine 0.5% with 0, 1, 1.5, or 2 microgram per kilogram of perineural dexmedetomidine. The primary outcomes were duration of analgesia, NRS, and consumption of additional analgesics within 36 hours. As you can see on this table, group D3 had a prolongation of duration of analgesia compared to group R, D1, or D2. And similarly for NRS scores at 18 hours, group D3 has a decrease in NRS score compared to the other groups. If you look at the Kaplan-Meier survival curve, group D3 has an increased time to first pain compared to the other three groups. There is no difference in rescue analgesics consumed within 36 hours, and as for the side effect profile, there is no difference in sedation score in the recovery room. However, there is a significant increase in bradycardia and hypotension in the dexmedetomidine groups compared to control. However, there are no significant differences between the dexmedetomidine groups. The second dose-finding study for perineural dexmedetomidine was Abdulatif in 2016 in Anesthesia. Abdulatif et al. Looked at femoral nerve block for arthroscopic knee surgery. Overall, they recruited 60 patients separated out into 4 groups, including control, 25, 50, or 75 microgram of dexmedetomidine. Importantly, the average weight of the patients in these 4 groups are between 70 to 75 kilograms. The primary outcome was the duration of sensory block. For 75 microgram of dexmedetomidine, it had a longer duration of sensory block as well as a longer time to first request to rescue postoperative analgesia. However, this came at an increased incidence of hypotension compared to the other 3 groups. Similar results were shown in Pachycebopathy 2017, where they studied femoral nerve block for total knee arthroplasty. They found a dose-response relationship between the dose of perineural dexmedetomidine up to 2 microgram per kilogram and the duration of analgesia. Therefore, based on current evidence, 2 microgram per kilogram of perineural dexmedetomidine prolongs analgesia the best, at the cost of increased side effects. Similarly, the optimal IV dexmedetomidine dose is also 2 microgram per kilogram, also at the cost of increased side effects. There was one dose-finding study for IV dexmedetomidine as a peripheral adjunct. This was published by Kang in 2018 as a single-center double-blinded randomized controlled trial. These included adults undergoing elective unilateral arthroscopic shoulder surgery under interscaling block. The patients were separated out into 4 groups: 0, 0.5, 1, or 2 microgram per kilogram of dexmedetomidine IV, which were administered over 30 minutes after induction of general anesthesia. What they found was that the duration of analgesia was significantly prolonged in the 2 microgram per kilogram IV dexmedetomidine group compared to all 3 other groups, while there were no differences between control, dexmedetomidine 0.5, and dexmedetomidine 1 microgram per kilogram groups. This was at a cost of increased hypotension in the dexmedetomidine groups. If you look at the Kaplan-Meier survival curve, then you can discover that the IV dexmedetomidine 2 microgram per kilogram group had a significantly longer duration of analgesia compared to all 3 other groups. Therefore, the optimal dexmedetomidine IV dose is 2 micrograms per kilogram at the cost of increased side effects. If you have to choose one adjunct between dexamethasone or dexmedetomidine, which one offers better analgesia? The answer is that dexamethasone is better by 2.5 hours in terms of duration of analgesia, with less hypotension and bradycardia. To look into this further, Albrecht et al. In 2019 published a systematic review and indirect meta-analysis based on upper extremity procedures under supraclavicular block with either perineural dexamethasone and/or dexmedetomidine. Databases were searched from inception until July 2017. 49 randomized controlled trials were included, with only one direct comparison between dexamethasone and dexmedetomidine. When compared to each other, dexamethasone offers a longer duration of analgesia by 148 minutes. On the other hand, dexmedetomidine has higher rates of hypotension and higher rates of sedation. Overall, the risk of bias was moderate, and publication bias was noted, resulting in low or very low evidence strength. Alist et al. Published in 2019 a single-centered randomized control trial of 120 patients undergoing upper limb surgery. These patients underwent infraclavicular block with either 5 mg of perineural dexamethasone or 100 micrograms of perineural dexmedetomidine. What they found was that in the dexamethasone arm, there were longer durations of motor block, sensory block, and postoperative analgesia. On the other hand, the dexmedetomidine arm had lower perioperative MAP and perioperative heart rate. Importantly, the Ramsey sedation scores were higher in the dexmedetomidine arm. This is important because given that the maximum Ramsey sedation score a patient may have before being discharged from PACU is 2, having most patients in the dexmedetomidine arm with a Ramsey sedation score of 4 may be a barrier to discharge, given that propofol sedation is still given to 52.5% of the dexmedetomidine arm. There could be room for utilizing less propofol. Importantly, because equipotent doses between dexmedetomidine and dexamethasone has not been established, this study should be considered as a dose-specific finding. And now for the finale. What happens when you use both adjuncts of dexamethasone and dexmedetomidine? The answer is early evidence suggests benefit. There are currently 2 randomized controlled trials evaluating the combined use of dexamethasone and dexmedetomidine. These are Kang 2019 and Zhang 2019. We will first examine Kang 2019 closely, as their methodology is very interesting and perhaps up for debate. Kang 2019 was a single-centered, double-blinded randomized control trial of 66 patients undergoing arthroscopic shoulder surgery. These patients had interscaling block with a 1:1:1 allocation to control group, D1 group, which had IV dexamethasone 0.11 mg per kilogram, or D2 group, which had IV dexamethasone 0.11 mg per kilogram plus IV dexmedetomidine 1 microgram per kilogram. The multimodal analgesia regimen was celecoxib 200 mg POQ12H. Interestingly, these patients had IV fentanyl PCA started if the patients were experiencing VAS score of over 2 at rest. The pump setting was fentanyl 15 microgram per mil with a continuous infusion of 1 ml per hour, a bolus of 1 ml with a 15-minute lockout time. Now, if despite the single-shot interscaling block and despite the IV fentanyl PCA, the patient still had a VAS score of over 4, then the patient receives IV morphine 10 mg as a rescue analgesic. The primary outcome was time from the end of block to the first rescue analgesic request, aka the morphine 10 mg IV. All patients were discharged on postoperative day 3. With this perhaps unconventional methodology, what Kang et al. Found was that the time to first rescue analgesic request was significantly longer for the D2 group compared to the D1 group, In fact, the D2 group had a very significant prolongation of time to first rescue analgesic request of 66.3 hours compared to the D1 group of only 17.4 hours. There were patients in the group that did not require rescue analgesic up to 72 hours. However, there was no statistically significant difference between the D1 and D2 groups. The patient's satisfaction with pain relief at 24 hours was significantly better in the D2 group compared to the D1 group. At 18 or 24 hours, the cumulative opioid consumption, or the VAS pain scores, were better in the D2 group compared to the other two groups. Now let's look at Jang 2019. It is a double-blinded randomized control trial of adult ASA 1 to 2 patients undergoing thoracoscopic pneumonectomy. They were otherwise healthy, without surgical complications. Their intervention was surgeon-performed 6-level intercostal nerve block under direct thoracoscopic vision, 5 mils per level, with a 1:1:1:1 allocation to Group R, which was the control group, Group RS, which was ropivacaine 0.5% plus perineural dexamethasone 10 milligrams, or Group RM, which was ropivacaine 0.5% plus perineural dexmedetomidine 1 microgram per kilogram, or Group RSM, which was ropivacaine 0.5% plus perineural dexamethasone and perineural dexmedetomidine. The primary outcome was duration of analgesia, which was defined as the time from block to first analgesic request. What they found was that compared to the other three groups, Group RSM had a longer duration of analgesia as well as a smaller total postoperative fentanyl consumption dose. If you look at the Kaplan-Meier survival plot, you will see that Group RSM had a longer time to first analgesic request compared to the other three groups, with a p-value of less than 0.001. In conclusion, without adjuvants, there is minimal benefit to single-shot peripheral nerve blocks with the cost of rebound pain. There is also a monetary cost to peripheral nerve blocks. Perineural dexamethasone works better than IV, but safety profile is unclear. The optimal perineural dexamethasone dose is 4 milligrams. The optimal IV dexamethasone dose is 4 to 10 milligrams, with possible or questionable increase in benefit from 4 to 10 milligrams. We're not sure if perineural or IV dexmedetomidine were equivalent, or if one were better than the other. The optimal IV or perineural dexmedetomidine dose is 2 microgram per kilogram, at the cost of increased side effects compared to the lower doses. Dexamethasone is better than dexmedetomidine as the sole adjuvant, with longer analgesia and less side effects. Preliminary evidence shows that dexamethasone and dexmedetomidine work even better together. Thank you for listening to my presentation.